Moving on from the first talk, it was a precision care of two lives. So here we move on to precision care of two organs. So which is what the AHA has coined as CKM syndrome. So the cardiovascular diseases, kidney diseases, and the metabolic diseases, which are type 2 diabetes, obesity, and hypertension, they frequently coexist. And the pathophysiology of all these diseases is more often than not shared. The risk factors are shared, the pathophysiology is shared. So due to the shared pathophysiological factors, there is a huge increase in the morbidity and mortality as well. So due to the growing burdens of the disease, and then the sheer amount of morbidity and mortality and the economic burden it puts on the family's perspective, the American Heart Association brought out a position statement in 2023 about cardiovascular kidney metabolic syndrome, detailing the risk factors of it, and it proposed a staging framework for CKM syndrome ranging from stages 0 to 4, and how to screen and where do we act in this continuum. So this CKM framework not only addresses the metabolic underpinnings of the disease, like addressing the risk factors such as obesity, diabetes, hypertriglyceridemia, it also expands the clinician's role in understanding the social determinants of health, which is economic microenvironments, the social hazards, and all these factors should be taken into consideration. This is a part of clinician's role as well, not to look at just the treatment from the pathological point of view. You also have to look at the economical, social determinants of health as well. So this has led to the paradigm shift in the management of type 2 diabetes from the last decade. So when you look at this ADA statement of 2015, the management and the complications was predominantly glucose-centric, where the complications are classically divided as microvascular complications, macrovascular complications, and the approach was to predominantly achieve a glucose control. The target was always to have a HbA1c of less than 7%. And the complications right from the beginning of diabetes was not given a center. So this changed when you look at the ADA statement of 2026. There is no first line, second line, third line therapy. The choice of therapy is to the discretion of the physician to address the cardiovascular risk factors, the chronic kidney disease risk factors, and the obesity as well. So the goal is to achieve the beta cell longevity. You don't start insulin right from the outset or somewhere less than a decade from the onset of diabetes. And the goal is also to prevent the cardiovascular mortality. So coming to the pathophysiology of CKM syndrome, as I told, it shares the pathophysiology among all the diseases. However, the core runner of the pathophysiology is obesity. As we call abdominal obesity, is the forerunner of all the metabolic complications of diabetes. So when there is perivascular and perirenal adipose tissue, the adipose tissue is not just the abdominal adiposity, which is the subcutaneous fat, the visceral fat, the intrarenal fat, which is around the glomerulus, and the perivascular fat, which is around the epicardial coronaries, triggers the inflammation. So this inflammation leads to release of cytokines, increases the oxidative stress, and this eventually leads to a state of insulin resistance. And when there is insulin resistance, again there is decrease in the nitric oxide, there is again increase in the vascular endothelial growth factors, increase in the vascular stiffness. So this leads to culmination of the microvascular and macrovascular complications, leading to metabolic syndrome, CKD, and cardiovascular diseases. So these are the risk factors associated with CKM syndrome. The AHA coined it as the essential 8, the essential healthy 8, which is diet, lack of a proper diet, physical activity, diabetes, hypertension, hypertriglyceridemia, and then dyslipidemia. So these are the 8, and then adequate sleep and nicotine. So these are the 8 core risk factors for CKM syndrome. So across India, when we look at these risk factors, the ICMR INDIAP study in 2017 projected the prevalence of these risk factors in CKM syndrome. As you can see, we can see that nearly 101 million people are suffering from diabetes, and more than that have pre-diabetes now at the present date. So due to these existent risk factors, there is a bidirectional pathophysiological interaction between the kidney and heart in type 2 diabetes. So coming to the AHA, as I told, going from pathophysiology to the staging of CKM syndrome, the stage 0 starts from the absence of risk factors. There is no risk factors. The job is to maintain a clean, healthy diet and maintain a weight with a BMI of less than 23, having an adequate sleep and quitting nicotine and taking care of your sugars, blood pressure and cholesterol levels. This forms the stage 0 of CKM syndrome, whereas stage 1 begins with the abdominal adiposity or obesity, wherein the pathophysiological processes start from this stage. Stage 2 is the presence of metabolic risk factors and CKD, which is a non-clinical CKD, or we can call it as high risk for CKD. So the metabolic risk factors include hypertriglyceridemia, diabetes, hypertension, and the presence of albuminuria or an EGFR of less than 60 ml per minute per meter square. So that is stage 2 CKD. This is where we should act to prevent the future clinical chronic kidney disease and clinical atherosclerotic cardiovascular diseases. Stage 3 is the presence of subclinical cardiovascular disease in patients with CKM syndrome. So there are two components of subclinical CVD. One is subclinical ASCVD, which is diagnosed by coronary artery calcium score of more than 100 or by coronary angiogram. There is subclinical heart failure, which is a second component of subclinical CVD. Subclinical heart failure is diagnosed by the presence of elevated NT-proBNP of more than 125 or elevated high sensitivity TROP-I and TROP-T, which have a specified intervals for different genders, male and female gender as well. The stage 4 is overt cardiovascular disease in patients with CKM syndrome, which includes coronary artery diseases which have manifested, heart failure either with preserved ejection fraction or with reduced ejection fraction, peripheral arterial diseases, stroke and atrial fibrillation. These form the component of clinical CVD in CKM syndrome. So this was a retrospective study which was conducted in China, which included patients who belonged to the hypertension survey of 2012 to 2015. So nearly 30,000 participants who had undergone an echocardiogram, who had urinary albumin creatinine ratio, who had the baseline determinants, demographic characteristics when they were assessed. This was the prevalence of CKM syndrome. The maximum prevalence was in stage 2. Stage 1, the prevalence was 19% and pretty much same as in stage 1 and stage 0, with 42% of prevalence being stage 2 and 14% of the patients belong to stage 3 and 9% of the patients belong to stage 4. So when you look at the prevalence by gender wise, males predominate all the components of CKM syndrome across all the stages of CKM syndrome from stage 3 to stage 5. However, there was female predominance in stage 0 and stage 1 of CKM syndrome. And when you look at the prevalence by age group as well, the advancing stages of the CKM syndrome, as we all know, that primarily belong to people more than 65 years of age, whereas the earlier stages of CKM syndrome were more prevalent in middle age groups. So why do we talk about prevalence? Because we can address the mortality associated with the prevalence across each stages. So when you look at the mortality rates from stage 0 to stage 4, there is increase in mortality rates by 3% across each stages. So the survival difference between CKM stage 0 and CKM stage 4 at 15 years was close to 8 months. So that was the staging of CKM syndrome. Coming to how do we prevent CKM syndrome? So the screening protocol was proposed by AHA, broadly classifying the public into two categories: the pediatric and young adults less than 21 years of age, and the second category being adult approach who are aged more than 21 years. So for the pediatric and young adult age groups, the annual assessment of BMI or obesity check is required with blood pressure monitoring starting from age 3. And for lipid parameters, the fasting lipid profile has to be obtained once between ages of 9 to 11 years and the second time between 70 to 21 years of age. And depending on the familial presence of risk factors, familial hypercholesterolemias and dyslipidemias, screening has to be started from age 2. If the risk factors are present, the screening for glucose intolerance and ALT also has to begin at an earlier age. So coming to the adult approach protocol, so routine BMI and waist circumference has to be measured annually for whosoever is more than 21 years of age, and the biochemical parameters which are HbA1c, lipid panels have to be measured at stage determined intervals, and specifically determined to organ detection, the key missing links that we routinely miss in our practice, measurement of albuminuria. So every patient must be screened for the presence of albuminuria, microalbuminuria, and EGFR measurement has to be done. And a fatty liver screening should be done every 1 to 2 years for metabolic dysfunction associated liver diseases. And a coronary artery calcium score has to be done to screen for subclinical coronary vascular diseases. So this is the approach to improve outcomes in patients with diabetes in CKD as stated by 2022. So initially, the chronic kidney disease management predominantly was the hypertension approach, the metabolic control approach, and the acid-base approach. Now the primary approach is to control the albuminuria, to reduce the intraglomerular pressure and to reduce the intraglomerular blood glucose levels. So that is the most important pathophysiological link that has been caught and which is put forth in statements and guidelines by KDIGO. So the SGLT2 inhibitors form a first line of therapy along with metformin for glucose control, and an additional therapy based on GLP-1 receptor agonists or non-steroidal mineralocorticoid receptor antagonists like finerenone can be used. So as we speak of treatment, how to address the CKM syndrome, so when we look at the class of molecules available for type 2 diabetes treatment, we have 7 to 8 classes of oral anti-diabetic agents and injectables, insulin apart one class, and the injectable GLP-1 receptor agonist form another class of treatment. So the traditional approach of metformin first, followed by sulfonylureas, followed by DPP-4 inhibitors, no more stands true. So the approach is to begin the treatment which provides longevity to the patient, which sustains a beta cell function for a longer time. So SGLT2 inhibitors take the cornerstone, form one of the cornerstones of treatment in CKM syndrome. So SGLT2 inhibitors, as we all know, were initially designed for glycemic control. The outcomes were destined to look for glycemic control. However, as the study outcomes were published in Credence, Declaritimi, and Emparage, so we could see cardiovascular benefits, 15 to 20% risk reduction in cardiovascular mortality across all the trials. So this has led to evolution of trials of SGLT2 inhibitors in heart failure per se and as well in CKD. So even in heart failure, the approach moved forward from heart failure with reduced ejection fraction to heart failure with preserved ejection fraction. So the DAPA-HF trial, which showed 22% mortality, 25% mortality reduction with dapagliflozin, similar results were replicated in the Emperor Reduce trial with empagliflozin reducing the cardiovascular mortality by 20 to 22%. So thereby forming the SGLT2 inhibitors as one of the pillars of management of heart failures. And with this, the second collateral benefit came forward. This does not apply to just diabetics. This SGLT2 inhibitors can be used in patients even without diabetes and even with normal ejection fraction. So this data came from the Deliver trial, wherein dapagliflozin was used in patients with preserved ejection fraction of more than 40%, what they say as mildly reduced ejection fraction or preserved ejection fraction. The Deliver trial showed that the mortality benefits even extended beyond heart failure with reduced ejection fraction. So this formed SGLT2 inhibitors to be one of the pillars of guideline-directed medical therapy in American Heart Association and American College of Cardiology ACC guidelines. So coming to the next class of agents, which is GLP-1 receptor agonist. So the progression, the story of GLP-1 receptor agonist began from exenatide, once weekly exenatide, liraglutide, albiglutide, dulaglutide. All these molecules were initially designed for again glycemic control. They proved their benefit with respect to A1C reduction of 0.5 to 1%. However, more fascinating was the amount of weight loss those medications could cause due to neurotransmitter changes and decreasing the appetite and increasing the satiety and delaying the gastric emptying. The amount of weight loss was beyond what was expected in the trials. It was close to 5 to 10% with initial class of GLP-1 receptor agonist. However, the latest addition to this GLP-1 receptor agonist category, which is semaglutide, causes close to 15 to 20% body weight reduction. When we see the body weight reduction, more than 80 to 90% of the participant could lose 5 to 10% of the body weight. So this was what ADA guidelines also suggested. A 7.5% body weight reduction could lead to improvement in the glycemic benefit. That was the target which was achieved by this GLP-1 receptor agonist. But beyond that, 15% weight reduction could lead to diabetes remission in few cases, and semaglutide could achieve that. So this led to the regulatory approval for use of GLP-1 receptor agonist in MASLD MASH, which is still pending. And patients and these GLP-1 receptor agonists also proved to be beneficial with respect to cardiovascular mortality and renal outcomes as well. So this is reducing the glucose levels. Now coming to reducing the intraglomerular blood pressure and improving the albuminuria purely from the CKD perspective, we all know that aldosterone was one of the molecule which had 30% mortality reduction when it comes to atherosclerotic cardiovascular diseases in the initial trials. However, there were few side effects with this molecule, spironolactone, which caused gynecomastia and hyperkalemia, and initial increase in the creatinine, which are the initial three adverse effects with molecule spironolactone. So then came the second generation molecule, which is eplerenone, which reduced the incidence of gynecomastia. The prevalence of hyperkalemia and decrease in the GFR also reduced a little with eplerenone, but it could still lead to some amount of hyperkalemia. But the latest molecule on the block, which is finerenone, as you all know, underwent two trials, which is Figaro DKD trial and Fidelio DKD trial, which both of the trials showed a decrease in the albuminuria by close to 30 to 40% reduction. Patients who were in the macroalbuminuric range came down to microalbuminuric range, and patients who were initially in the microalbuminuric range resolved to normoalbuminuria. So that was the benefit which was shown by finerenone, with least effect on hyperkalemia, creatinine, and no effect on gynecomastia. So this proves that finerenone could be one of the pillars for management of albuminuria in CKD patients, thereby providing holistic approach to the management of CKM syndrome. So we have to act at stages 1 to 3. Stage 4 and stage 5, it is symptomatic treatment. Everybody knows the goal of the physician is to prevent the morbidity. So we need to act on stages 1 to 3. So in patients with diabetes, apart from glycemic control, dyslipidemia, and blood pressure control, we need to address albuminuria, so which is quite possible with the available newer molecules. So these are the few investigational molecules which are in phase 3 trials for CKM syndrome, predominantly targeting the lipid parameters, lipoprotein A levels, interleukin 6 blockers, so which are on still trials. So I thank you. I thank Endocrine Society of Rajkot and Association of Physicians Rajkot and IMA Rajkot for having me here on their first meet. Thank you all.